Hello everyone. So I will tell you about the Hirschsprung disease. So Hirschsprung disease is a genetical disease where the neural crest cells are not able to migrate to the lower GI part. So that's why the parasympathetic ganglions will not able to form and they will not be able to present in the lower GIT. So the lower part will be able to contract but not be able to relax. So this is the Hirschsprung disease. There will be the continuous contraction. So I will tell you the management part. There are the three surgical procedure, which is called the pull-through procedure. The number one is that very common, which is known as Swenson procedure. Number two, Duhamel procedure. Number three, SOAP procedure. Swenson procedure means it's a procedure where we take the ball which is healthy and we found the ball which is narrow because the plexus, the myenteric and mesenteric plexus are there, but the ganglia is not present, so there is a ganglion part, so it will be contract. So we have to resect it, we have to cut it, and we have to take it. And the part that is anal canal, the healthy part, we should be pull it down and we should able to anastomosis with the anal canal. We should make sure that the upper healthy part should be easy mobile. The blood supply should be maintained, so that's why we have to cut it very carefully. We have to cut it, then we have to pull it down, and we have to anastomose with the anal canal. So it's a very simple procedure. This is known as the original full resection. It is called a complete dissection. Another is the Duhamel procedure. Duhamel procedure means Duhamel was actually a Swenson student. Like, we can understand that his fingers were small, so he was not able to suture completely to the anal canal. His fingers was only reaching towards the rectum. So what he do, he developed a new surgery which is called a Duhamel procedure of pull through. Here what he does, he took the healthy part of the colon and he pull it, and the diseased part of the rectum he made an incision on the back side of the disease and the anterior side of the healthy colon, and he fused it and he anastomosed it by the sutures and all. So what happened, the canal will become more wider, so the feces can easily come and it can easily go down. And here the plexus will be there, the mesenteric plexus will be there because of the healthy part, so it can easily go down. So this is a very good surgery, which is known as the Duhamel procedure, which can be joined the anterior part of the diseased ball and the posterior part of the posterior side healthy ball is there, so we combine it. So this is a Duhamel procedure. So it is a very good procedure. Just because his finger were small, God gave him a different plan. He developed a new different surgery so that the surgeons can explore this and can help. So now I will talk about the SOAP procedure, which is called as the endorectal pull through, which is a very best method. You know what happened in this procedure? In this procedure, we know there is a diseased bowel and the healthy bowel. Healthy bowel will be upside and diseased bowel will be the lower side, because neural crest cells are not there, so ganglia will be not there. Parasympathetic ganglia will not be there, so the bowel motility is very poor, very low. So what will happen? We have the healthy bowel. We have to just connect the healthy bowel to the anal canal. So what we do, we have a diseased bowel on the lower side. We know the small intestine and large intestine, every bowel we have a layer, mucosa, submucosa, muscularis purpura and the serosa. In this case, the diseased bowel case, we will remove the mucosa layer and the submucosa layer. So if the mucosa and submucosa layer will not be there, so this wall become thin. The wall become thin, it will behave like a flap. So it will behave like a flap. We will call it a kind of a protective wall kind of thing. Muscular wall, muscular outside muscular wall, or outer muscular sleeve, also known as the muscular tube or aganglionic muscular tube. Because the ganglia is not present, so we will call it aganglionic muscular tube, or it is present outside, or we will call it outer muscular sleeve. So what will happen, we have removed the muscle and the submucosal part, then we will do we have the diseased part on the lower side, and we have removed the mucosa and submucosal layer of that layer, so it will become thin. And upper part we have a healthy bowel, so we have to pull through down. We will pull through down, and this layer will go outside. This layer will be the outside, and the healthy bowel will be go inside. Just like we have, like, just like I want example, you know, there is a cement bag. We take the two cement bag, upper there is a one cement bag, there is a down, there is a lower cement bag, upper cement bag and lower cement bag. The upper cement bag should be go inside the lower cement bag, so the lower cement bag will be like that, and the upper cement bag will be inside. So what will happen, the disease bowel part, it acting as a lower cement bag, so it is on the lateral side. It is protecting the healthy bowel, and the the healthy part is inside that. And you know what is the benefit of this surgery? Why are we doing this? Because outside the anal canal and outside the rectum, there are the superior and inferior hypogastric plexus, and also there is an inferior rectal nerve. So these nerves are there, and most importantly, outside the rectum there is pelvic splanchnic nerve. Pelvic splanchnic nerve is an autonomic nerve, which is a very important nerve. What happen actually if this nerve get injured? So our micturition reflex, our bowel motility, and sexual arousal will go. So these things will go if the nerve injury has done. So what should we do? We have to obviously save it. We have to obviously protect this nerve. So how will we protect it? We do one thing. We have this, just like I have given example, like a bag. You know, the upper bag is going inside and the lower bag is going on downside. It is like a lateral side, so it is protecting. So this nerve is present on the lateral side, it will protect the nerve. When we are doing surgery, there are chances that the instrument can injure the nerve, and a problem can happen. So what is happening here? There is a muscular wall, I told you, right? There is a muscular wall, a ganglionic muscular tube also, which is acting as a protection. It is protecting the pelvic nerve to get injured due to the surgery that is done, because we are doing surgery inside the anal canal. So we are just thinking, and we are just working inside the anal canal, and we are just taking the part of which is the healthy bowel. Inside the healthy bowel we are working, and outside the healthy bowel there is a diseased bowel layer of muscle layer is there. This muscle layer is acting as a barrier, protecting barrier. So that's why, because of that, we are able to save the pelvic nerve, pelvic splanchnic nerve, as well as the pudendal nerve. Pudendal nerve is responsible for the voluntary control of the micturition, and the pelvic splanchnic nerve is responsible for the micturition reflex. If this nerve will be go, there can be element lesion can occur. Element lesion of the bladder, it can lead to the flaccid paralysis. It can lead to autonomic bladder, because it is arising from the S2 to S4 segment, which is called a sacral plexus. It will cause the element lesion. What happened in the element lesion? The bladder will be there, the element lesion is gone, spinal reflex will be gone, so we will not able to feel, we will not get the urgency of to micturate. So what will happen? The urine will collect, it will get bag, the urine bag will get expand, bladder will get expand, and then what will happen when the bladder get expand? We will not get the feeling, we will not get the urge to release the urine. So ultimately this bladder will relax or release the urine, which is called incontinence. It is called a urine incontinence. We will not able to recognize that we are having this reflex. Our micturition reflex will be gone, so this problem can occur. And another is the loss of the bowel motility. The bowel motility will also gone. There is no benefit of the surgery. We have done the surgery to protect the bowel motility. If the problem is sustained, then there is no point. Our surgery is failed. Third point is the loss of the sexual arousal. If this nerve has damage, so obviously it can affect the fertility of the patient, and it can cause the future related issues. So I hope this concept was beneficial about the management of this part. It is a concept of a pediatric surgery part. So I hope you liked it. Thank you for listening me, and have a nice day.